I am the Director of Analytical Chemistry at the Massachusetts Department of Public Health. And so my role in public health is probably a little different than the other panelists. I'm with the laboratory, and so people may not always think of a chemist or a microbiologist as working in public health, but there are many of us. My group is very diverse in that we look at primarily human exposures to chemicals. So we have a very large, high-volume laboratory that looks at childhood lead poisoning. We test about 90,000 samples a year for kids to determine whether or not they have elevated lead levels. We look at people who live near hazardous waste areas, or who, if our epidemiologists indicate there's a cluster of disease in a particular area that may be related to a chemical exposure, we might look at people in those areas in cooperation with our environmental health staff. We have a very active chemical threat response laboratory where we respond to white powder incidents after they're cleared for microbiological agents. We will test them to determine what they are, as well as testing people for exposure to chemical threat agents. And lastly, the last lab I have is not what you would typically think of as public health, but we test forensic drug specimens for law enforcement purposes. And we like to think that it's public health because we're helping to get drug dealers off the street and make drugs a little less available to the population.
My name is Amy Guerra, and I work for the Boston Public Health Commission. I went and did internships in a nursing home. I worked for the Mass Society for the Prevention of Cruelty to Children as an intern, and worked in their Healthy Families program, which is a team parenting program. So you actually go and do home visits. And I worked in the Holyoke, Chicopee, and Springfield areas of Massachusetts doing that. And I also did, some tutoring for school-age children and that sort of thing, just to give myself a really good breadth of knowledge about what was available to me, especially for careers. So by the time I was a senior in college, I decided that I wanted to continue to work for MSPCC, which is the shortened version, and actually do the home visiting. So I became a home visitor in Lynn, Massachusetts. My career then took me to working for Boston Healthcare for the Homeless program. And that program, I was a case manager as well, just a little different because at that point I was actually on site at one building. It was a medical respite facility. And so my job was mainly discharge planning, which is a considerable job when people are homeless and they don't necessarily have a discharge plan. So you have to decide with that person, what are their goals? Is it a short-term goal, is it a long-term goal, and how can I, in the setting of 3 weeks, a month, the average length of stay, get them to the next step? So a lot of times that did involve substance abuse recovery. So I was doing a lot of referrals to substance abuse agencies, housing advocacy, filled out a number of Boston Housing Authority applications, and I had the good fortune of supervising some AmeriCorps volunteers, so they actually would take over those responsibilities. But it was a lot of mentoring, so I got to really see almost the other side of the healthcare field in terms of other people that were looking at what they wanted to do with their career, so that was kind of fun. So my focus was actually in the leadership part of communications, so looking at how a team can best function, and how my role as a leader, can benefit my team. So that was really awesome. And because I was doing committee work on the side and doing event and consulting and all of that, I was actually encouraged to apply for the position I have now, which is Volunteer Services Coordinator, by one of the organizations that I was doing committee work for, Friends of Boston's Homeless. So they told me about the job, I got the job, and that's where I've been for almost a year and a half now.
My name is Brian Engelson. I am currently a research assistant at the Division of Infectious Diseases HIV Vaccine Trials Unit at Brigham and Women's Hospital. What do I do as a research assistant? That's a very broad term. It doesn't really tell you anything. The key point here is that research assistants wear many, many hats. Technically, I am the regulatory coordinator. That means I work with all of the paperwork that our sponsor sends us, the FDA sends us, as well as everything happening with the protocol, such as recruitment materials. All of that sort of goes through me. I look at it, make sure it's cleaned up and appropriate to send to an IRB, which is an internal review board or ethics committee, as well as our IBC, which is an internal biosafety committee, or COMS, which is Committee of Microbiological Safety, as well as looking at community advisory boards, which are actual community members to help work with us to formulate how the research will move forward. And along with those regulatory responsibilities, one of my hats is also recruitment. Recruitment is your most basic direct impact with the public. You're going out, you're doing street team efforts, you're talking to people about awareness for HIV prevention or participation in the trial. You're giving away free stuff, t-shirts, bags, condoms, whatever. And then I have another hat, which is my community education, probably most directly linked to public health. Community education, similar to recruitment, it means going out to health fairs and events, but not simply to say, hey, our trials are great, come join them, but to say, here's the status of research in HIV and HIV prevention. We work specifically with vaccines, but there are also microbicide gel efforts and prophylactic methods with pills. We have to be familiar with all of that and sort of disseminate that knowledge out to the general public, as well as our peer supporters. Then finally, one of my hats that incorporates all three of the previous occupancies is clinical. In the clinic, I do have to schedule people, very basic, but necessary to work with their schedules to come in. And then once they're scheduled, I actually see them for their screening visits. And a screening visit is, again, that dissemination of knowledge that recruitment and community education rely upon. Those documents I sent through the IRB and regulatory, they are right in front of me. I'm explaining it to the person. I'm letting them know about HIV awareness, way to protect themselves, what's involved with the trial. Informed consent process is a very important public matter. Anything that you put on paper and have someone sign, they need to be aware about all the risks and benefits of what you're asking for them to do in the trial. A lot of what we do working with the HIV Vaccine Trials Network is international. Public health, sometimes you get narrowed into thinking my locale, my city, my community. But you're also addressing multiple communities in many cities all around the world, especially with something like HIV.
I'm Jean McGuire. I just returned to Northeastern after 6 years back in government. I was an assistant secretary for health here in the state in my most recent term in government, and I'm what they call professor of practice in the Bouvet College of Health Sciences, teaching upper level and graduate courses, and right now I teach the health policy course. I think the platform of public health, when it's relevant, regardless of, and you make a good point, you've come from biology or psychology or education or things that have led you, communications, etc., into this arena of public health, is thinking about the ability that there has to be a literacy and a shared language across the disciplines, and that's something you can be developing now while you're in school. Didn't go to any public health classes until I was 40, and I had already been practicing the field, led a national organization, testified on FDA drug development and alternative surrogate endpoints. My undergraduate degree was in psychology, and really my path towards work started with working with affected people themselves. I started out in special education and in the institutional settings with predominantly what we now call developmentally disabled people, although frankly there were a lot of people that were in there for a lot of different reasons at the time. I went from that because I looked around and said people needed a different life and started developing community residences. I went from that because they wouldn't let me put the community residences in some of the nice parts in town to working on zoning policy and housing policy, including over time federal policy in that arena. And then I went to managing
many sites and many services because I wanted to try management and I wanted to test out whether you could make money and do good. Then I became a lobbyist at the national level, and I basically was a lobbyist for about 10 years. And various disability arenas. Oh, I had a short stint after I got fired in a methadone clinic, which was also eye-opening. Since that period of time, I've been in and out of public administration as an assistant commissioner of health here in the state, and then back again this time as an assistant secretary of health, in the first case with the infectious disease portfolio, and the second case with disability and long-term care. And in between, I've taught here and I've done consultant work. So I think the thing I would reiterate, multiple paths into public health. The recent passage of the Affordable Care Act and its implementation gives you a signal about how health is everywhere, and there's an all-health framework that the government is now using.